Hello, everyone, and thank you so much for joining me today. We're going to talk about identifying and managing gestational diabetes. My name is Jane Seley. I'm a nurse practitioner and a diabetes care and education specialist at Weill Cornell Medicine in New York City. And these are the topics we're going to cover: screening and diagnosis, monitoring, meal planning, physical activity. Then we're going to do a summary of the management plan for gestational diabetes, and I'm going to show you some great patient education resources. So let's get started. How do we identify gestational diabetes? So, by definition, gestational diabetes means that the person was not told they have diabetes prior to pregnancy. It appears during the pregnancy itself, and it affects actually about 14% of all pregnancies worldwide, or 18 million births per year. So it's very common. Why does this happen? Because hormones produced by the placenta and the fetus heighten insulin resistance during pregnancy, and the body has to work much harder to produce enough working insulin to keep the glucose levels at goal. And glucose goals during pregnancy are actually lower, so it makes it harder to achieve and maintain these glycemic goals. So an A1C during pregnancy is actually slightly lower than an A1C when you're not pregnant because of the more rapid red blood cell turnover. That means that red blood cell isn't hanging out as long to get covered with glucose every time the glucose goes up. It coats the outside of the red blood cell. And that's what the A1C measures, is the exposure to glucose over time. So if the red blood cells are turning over more quickly, they're not exposed for as long. So the normal goal for pregnancy A1C is less than 6%. So this is a look at the prevalence of gestational diabetes across the globe. So, for example, in the Middle East, the range is between 8.4 and 24.5%, with a median prevalence of 12.9% of people who are pregnant have gestational diabetes. Whereas in North America, in the Caribbean, the median is 7% of the population, with it being a range of 6.5 to 11.9% of the population. So in the Middle East and North Africa, gestational diabetes is very, very prevalent. It's very important to screen. So who are at risk? Women over 35. If someone has excess weight before they become pregnant, if they're not physically active before they become pregnant, if they have a family history of diabetes, and all of these different measures of insulin resistance, like they had gestational diabetes in a prior pregnancy, doesn't mean 100% of the time they'll have it with the next pregnancy, but their risk is much higher, and we have to pay close attention to them. If they have a history of prediabetes, if they've had polycystic ovary syndrome, PCOS, or an elevated triglyceride level of over 150. Another risk factor is a prior stillbirth or a baby weighing over 9 pounds. Some women who are diagnosed with gestational diabetes actually have no risk factors. And another problem is they have no symptoms many times. So all pregnant women should be screened by the second trimester of pregnancy, usually the 24th to 28th week, to see if they have gestational diabetes. But if we think they're at high risk, we should screen them earlier, certainly by the 15th week. But many times, if we're really concerned about their risks, such as gestational diabetes in an earlier pregnancy, we would actually screen them at the first prenatal visit. Once they're diagnosed with gestational diabetes, we have found that lowering glucose levels and maintaining those levels at goal during the pregnancy is key to the health of both the mother and the baby. So there's two different ways you can screen. Both of them are supported by the different guidelines from the Diabetes Association and the obstetric societies. One is the one step. So this is, of course, easier because it's only one step. However, drinking 75 grams of glucose when you're pregnant is not easy. Many people get nauseous or even vomit. So it's 75-gram glucose challenge after at least an 8-hour fast overnight. The fasting should be less than 92 milligrams per deciliter or 5.1 millimoles. The 1 hour should be less than 180 milligrams per deciliter or 10 millimoles, and the 2 hours should be less than 153 or 8.5 millimoles. The two-step is a little bit more complicated, but it's easier to screen people with a 50-gram glucose challenge than a 75-gram glucose challenge. So you could weed out the people that are unlikely to have it. So if you do a 50-gram glucose challenge and you check the glucose at exactly 1 hour, there's a range of opinions of the glucose in milligrams being anywhere from 130 to 140 to opt in and go on to the glucose challenge with 100 grams, or 7.2 to 7.7 millimoles. Personally, I use the 130 milligrams per deciliter or 7.2 millimoles as the cut point, so I don't miss anybody. If you use a higher goal, you can miss some people. So once they are higher than that level, we do the 100-gram glucose challenge. And if at least two of these glucoses are elevated, then they would be considered to have gestational diabetes. In my long experience with taking care of people with gestational diabetes, I find that quite commonly, as long as the fasting is elevated, even if the others are not yet, they probably have gestational diabetes. And the treatment is meal planning and physical activity, so there's no harm in going ahead and doing that anyway and seeing what happens. So why does it matter? Because the increased risk for women, if untreated during pregnancy, is hypertension, which can increase their risk of preeclampsia and eclampsia, and macrosomia, or large babies. At birth, if the baby is too large, it's a difficult delivery and it can cause shoulder dystocia or even a cesarean section. So we want to try to avoid this. The other interesting thing is the baby may be born with hypoglycemia because they've suddenly left this high glucose environment in the mother and they're in a normal glucose situation. So they may actually get low at the beginning. We have to monitor them very closely. Later in life, we also have to monitor both the mother and the baby. The mother's risk for type 2 diabetes is much higher, but for the baby, all the way through life, they are at higher risk for childhood obesity, impaired glucose tolerance, and metabolic syndrome. So high glucose, high blood pressure, high cholesterol, and excess weight. So we have to monitor them very closely. So in the American Diabetes Association Standards of Care, in their section on management of diabetes during pregnancy, they have this really excellent checklist for preconception counseling for women who are going on to become pregnant, and especially if they have a history with gestational diabetes. And there's much information here which you can read at your leisure. This is available open access online. But the one thing I want to point out here is that it's very important we review their current medications before they become pregnant to determine whether they're appropriate during pregnancy. And this is a continuation of that checklist. The other thing they discuss is start talking about nutrition, losing weight before they get pregnant, medication they might have to stop taking when they become pregnant, and what are the glycemic goals prior to conception. We want them to also start having lower blood glucoses, so when they become pregnant, it's easier to reach that goal of an A1C less than 6% from the get-go. Glucose monitoring is extremely important in determining whether the lifestyle changes is enough or the person has to go on to pharmacologic therapy. The first choice is always insulin. So let's talk about monitoring. The glucose is recommended to be checked differently in pregnancy than non-pregnant women. So you check fasting when the person first wakes up in the morning, and it should be less than 95 milligrams per deciliter or 5.3 millimoles. And there's a difference of opinion. It doesn't really make a difference if you check 1 hour postprandial or 2 hours postprandial. The clinician decides which one they want to ask for, and the person continues to check that one time. So if it's 1 hour after the first bite of the meal, then the goal should be lower than 140 milligrams per deciliter or 7.8 millimoles. And if it's 2 hours after the first bite, it's lower than 120 milligrams per deciliter or 6.6 millimoles. is a good idea to set alerts, especially in the phone or any way that someone wants to set alerts or reminders. You can use, setting a timer on the phone or asking Siri for help. Any method that the person wants to use, because it's hard to remember exactly an hour later or exactly 2 hours later. I just want to review quickly how to get an accurate blood glucose check because it's really important it's done correctly. We recommend washing the hands with warm water and soap, not using alcohol. Alcohol is very drying to the skin, and wet alcohol will dilute the blood specimen. Getting all the supplies ready first. So you have the lancing device, the lancet is loaded in the lancing device, not using a lancing device and just a bare lancet to stick the finger can be very invasive and cause some trauma to the skin. So it's better to use the lancing device so it allows the lancet to go just as far in as it should. Have everything ready. The glucose strips are out. The meter is ready to go. Open up the vial of test strips, put the test strip into the meter, but not all the way in so it turns on, but have it ready. Close that test strip vial, and now you're ready to go. Hands are washed, lancing device is loaded, meter is ready to go. Push that test strip in, stick the finger. Good idea to anchor the finger on one's lap or on a table so you can't pull away from that lancet. So you get a good contact, so you get a nice specimen, and go ahead and do the test. Again, the recommendation is to do it fasting upon awakening in the morning and either 1 or 2 hours after each meal. And it's also recommended to change the lancet at least once a day so it's sharper and has more lubricant left on it so it glides into the skin more easily. There's different goals for people with gestational diabetes that take insulin versus don't take insulin. So if they're not taking insulin, we're not worried about hypoglycemia because we're not giving them a medication that causes hypoglycemia. So the fasting could be less than 95 milligrams per deciliter or 5.3 millimoles. And the 1 hour or 2 hour postprandial, we just say less than the tipping point number. We also are concerned about the use of oral antihyperglycemic agents during gestational diabetes. Metformin and sulfonylureas, especially glyburide, were commonly used for many years, believing that they did, in fact, not cross the placenta, but in fact they do. So we try to not use them, especially as a first-line agent. If metformin was used for the person to become pregnant, because it can induce ovulation, especially with people with PCOS, we should discontinue the metformin by the first trimester of pregnancy. Other oral and non-insulin injectable diabetes medications have no long-term safety data and are not recommended during pregnancy. Insulin is the preferred pharmacological treatment for gestational diabetes during pregnancy, and with insulin, you could always get to goal. So how do we start insulin? We look at the glucoses that are out of range, and we base it on that. So if the fasting glucose is the one that's elevated, then we would consider NPH if only the fasting is elevated, but the postprandial glucoses are okay. The reason we choose NPH is, as an intermediate acting insulin, it lasts about 10 to 12 hours. So if the person takes it just before they go to bed at night, it will just lower their fasting blood sugar in the morning, but it won't cause them to have low sugar during the rest of the day. Some people will also need rapid acting insulin for their meals. We prefer rapid acting over regular insulin because it's rapid. So it starts to work right away to start lowering that glucose when the person starts eating. And some people will need both intermediate or long acting insulin along with the rapid acting insulin for their meals. So they'll need to lower their fasting and also to lower their postprandial glucoses. If they need both, then I would probably just go ahead and use a long-acting insulin like Glargine and not NPH because they need help throughout the day. And then again, we would prefer a rapid-acting insulin over regular insulin because it works faster and doesn't last as long. So this is the goals now for someone taking insulin because we don't want them getting low. So you see that we have a range now from this to this, whereas before we just said less than the tipping point number. So for fasting, the range would be 70 to 95 milligrams per deciliter, which is 3.9 to 5.3 millimoles. And for people doing 1 hour postprandials, they shouldn't be below 110 milligrams per deciliter or 6.1 millimoles. And for 2 hour postprandial, they shouldn't go below 100 milligrams per deciliter or less than 5.6 millimoles. So how do we start insulin therapy? So this is a simple guideline that I put together for you um, to give you a good idea about how to start. But remember that clinical judgment always matters. So fasting glucose is too high, then you want to start the NPH if it's only the fasting that's too high. But if it's the fasting and the postprandials, then you would want to start glargine. How do you do that? You take the weight in kilograms, and I've given you a range based on your clinical judgment of how insulin resistant you think this person is. So anywhere from 0.1 to 0.2 units per kilogram when you calculate the at times the weight, as we did here in this example. The number you get is their total dose of the basal or intermediate acting insulin. And then you can choose to round up or down based on your clinical judgment. If you think that they are resistant and could use the full amount, you go ahead and give them 18 units. If you want to err on the safer side, you can start with 17 and see what happens. For the bolus insulin, same principle. If they've exceeded the goal for the 1 hour or 2 hour postprandial, then we're going to use rapid acting insulin if possible over regular human insulin to lower that postprandial rise. Again, we're going to do the weight in kilograms times the range. So you're going to decide anywhere between 0.1 and 0.2 units per kilogram. In this case, I went in the middle. I'm not sure. I'm going to try in the middle one, 0.15 times the weight in kilograms. I get 11.4 units. And now I'm going to take that number, and that's all of their mealtime insulin. So I'm going to divide it by 3. So each meal, they're going to get 1/3 of the dose. In this case, it would be 3.8 units, which I might round up to 4 units, or you could round down to 3 and see how it goes. So once you started the insulin therapy, you're going to play a role in closely watching how they do and titrating their dose frequently. Unlike in someone with type 2 diabetes, when you might wait a period of time, these are pregnant women. We want to look at these numbers at least once a week and make a decision, especially when we're starting the insulin. So adjusting therapy is based on a 10 or 20% rule. We're either going to increase or decrease the dose by 10 or 20% based on how high or how low the glucose is. So for the fasting, if it's between 95 milligrams per deciliter and 120 or 5.3 to 6.7 millimoles, that's not very high of an increase, so we're going to increase it by 10%. And if it's exceeding 120 milligrams per deciliter or 6.7 millimoles, we're going to increase it by 20%. So the same idea goes with the 1 hour and 2 hour postprandials. So if it's high but not higher than this number, we increase by 10%. And if it's above that number, in this case, it's 160 milligrams per deciliter is the tipping point, or 8.8 millimoles, then we would increase by 20%. And the same would hold true, but with the 2 hour postprandial, if it's between 120 milligrams per deciliter and 140, or 6.7 to 7.8 millimoles, then we would only increase by 10%. But if they're over 140 or 7.8 millimoles, we will increase by 20%. And then keep titrating based on that principle. Next up is ketones. Ketone testing is very important during pregnancy. We don't want the mother to go to sleep at night without having enough calories burning for the baby. So we want to have enough carbohydrates on board for energy. If they don't have enough carbohydrates, then the way we can measure that is by checking ketones, because that's telling us when they can no longer use carbohydrates for energy and they're burning fat, and fat produces ketones. So checking ketones helps you know if the mother and the baby are getting enough carbs during the night while the mother is sleeping. And of course, it also tells if the person is going into diabetic ketoacidosis, so it's a good early warning system. The recommendation is to advise women who are pregnant to check their ketones first thing in the morning with that first urine, and If they have trace and small ketones, occasionally that's okay, but if it's more common or they're having moderate to large ketones, they should get in touch with their healthcare team right away. So this is how to do it. It's very, very simple. It's important to teach people how to do it so they do it correctly. So they're going to collect some urine in a small cup, or some people do pee on the strip. If they can do that, okay, fine. Probably hard when you're pregnant to do that, but okay. Shake off the extra urine is important. Let it sit for at least 15 seconds and compare the color change on the vial, as you see here in the picture. And if they, in fact, do start spilling ketones, we want to make sure to prevent this that they snack before bed with a 15 to 20 gram carbohydrate snack that has some protein and fat to slow down that carbohydrate so it lasts longer. Now let's talk about meal planning. So meal planning and physical activity are the first and very important treatments for gestational diabetes. It's very different in pregnancy. We tell people to follow a different meal plan so that each meal and each snack is not a lot of carbs at once to prevent their glucose from going up too high after a meal or snack. So they're going to have 3 main meals and 3 snacks carefully timed at least 2 hours apart. So when you eat breakfast, you wait 2 hours before you eat your first snack, at least 2 hours. You wait at least 2 hours after that snack before you eat lunch, and so on. Having that last snack after dinner, just before bed, will help to prevent inadequate caloric intake for the baby while you're sleeping. So the calories are limited to about 180 grams per day, which means the breakfast, because people are much more insulin resistant in the morning because of the pregnancy hormones, will only be 30 grams of carb. The lunch will be 45 grams of carb. Dinner will be 60 grams of carb. And each of the 3 snacks will be 15 to 20 grams. So breakfast, 30 grams or 2 carb servings. Lunch, 45 grams or 3 carb servings. And dinner, 60 grams or 4 carb servings. And each snack is only 1 carb serving. So here's a great list of many foods with the portion sizes. Each portion size is 1 carb serving. So this is a good way to compare one food from the other and make some good decisions on which one you might want to have. So for example, 1 slice of bread has about the same amount of carbohydrates as a half a piece of pita, sorry. So if you eat a whole pita, you already had 2 carb servings. Cereal is different if it's cold cereal, hot cereal. Hot cereal is a much smaller portion. You can see a half a cup or 120 milliliters, whereas cold cereal is 3/4 of a cup or 180 milliliters. So this is how people can make decisions knowing the portion sizes for 1 serving, and then they can decide whether they want to have 1 serving of that food, or if they have enough carb servings for that meal, they might want to double up on something they really like. Milk and yogurt. Milk is pretty good. It's only about 12 grams of carbohydrate in a cup of milk or 240 milliliters. Yogurt varies by the type of yogurt and what's in the yogurt. So we recommend using plain yogurt and putting your own fruit into the yogurt, like berries into the yogurt, then using fruits that might have a lot of sugar in them, like pineapple and apples and things like that. Berries would have a lot less, and that might work better to not cause a rise in glucose. If Greek yogurt is available, Greek yogurt is actually lower in carbohydrate than regular yogurt, so the serving size will be larger. I've shown you a whole bunch of fruits here because they're all very different. So a small apple is usually 15 grams. Bananas are often very long, so a half a banana might be 15 grams. Melon and berries, you get to have a whole cup or 240 milliliters. Pineapples and grapes are really sweet, so the portion sizes are smaller, and so on. Starchy vegetables are something people really like to have. As a general rule of thumb, the portion size for a starchy vegetable would be 2 carb servings, would be 1 cup or 240 milliliters of potatoes or corn or green peas, things like that, zucchini. Beans, chickpeas, lentils, they're all delicious, have protein, but also have carbohydrate. So the portion sizes do need to be measured. But then there's all these carbohydrates here that are non-starchy vegetables and low in carbohydrate. So I don't really ask people to measure them. I tell them to enjoy them as much as they want, but really be careful of these carbohydrates that have to be measured. So things like eggplant and salad and green beans and cauliflower and broccoli, asparagus are all very low in carbohydrate. As far as snacks and desserts goes, probably one of your better desserts would be to have some fresh fruit in the proper amounts that I just mentioned. If you do have some kind of sweet, the general rule of thumb for a piece of pie or some kind of desserts is a 5.5 centimeter small square of it, or looking at the label that it came from. If you get it from a bakery, it's harder, you don't know, so you could stick to, let's say, two small cookies. But if you actually have the package, you can see exactly how many cookies you can eat. That would be 15 to 20 grams. Ice cream is also a good bet. You could have a half a cup or 120 milliliters of a plain ice cream. Be careful of ice creams that have a lot of sugar added, like salted caramel is very popular now, and it has a lot of extra sugar in it. So each portion size on this whole chart is 15 grams of carbohydrate. So basic principles of healthy eating during pregnancy. They need extra dairy products to get their calcium and vitamin D, so meat, milk, and yogurt do need to be measured. Cheese does not. Plenty of low-carb starchy vegetables. They don't need to be measured, and that will help people feel full and get lots of vitamins and minerals. Lean protein, like fish, shellfish, poultry, um, eggs, tofu, all of these things are fine and will help the carbohydrate take longer to break down, as will fat. Small servings of whole fruits, so remember to measure the fruits, and that melon and berries are the better deal because you could eat more of it. No fruit juice. Fruit juice is a treatment for low blood sugar. It makes the sugar go up, wow, really fast. So you don't want to drink it just to drink it. Think about healthy oils like olive oil, canola oil, and avocado oil, avoiding lard and butter. Drinking plain water is terrific, and unsweetened tea, seltzer. Be careful of artificial sweeteners. We really want to limit them or avoid them during pregnancy. There's not a lot of good data on their safety while pregnant. And prenatal vitamins, ask your healthcare team about that. So think about the healthy choices we just mentioned and stay away from things like refined grains like white bread, white rice, plain pasta. Bagels, oh boy, bagels have probably the equivalent of 5 or 6 pieces of bread. One trick with bagels, if you really want to eat them, is to scoop out the inside and you'll have a lot less carbohydrate, or eat half a scooped out bagel, which tastes just as good with some egg salad or tuna salad on it. Uh, Flavored milk and yogurts with berries and things in them already have a lot more sugar. Dried fruits have a lot more sugar, and fruit that's canned in juice or syrup, be very careful of that. All the different sweets we just talked about. And snack foods can have a lot of carbohydrates, so try to read labels and know exactly what the portion size is. Fruit smoothies make the glucose go up very, very rapidly. So reading a label is really important, especially during pregnancy. So I divided into 3 steps. First step, look at the serving size. The serving size is how much they're talking about, maybe not how much you're eating. So once you see how much carbohydrate is in the serving size, you can decide whether or not you want to eat that full amount, or maybe you want to eat less of it, or maybe you can even eat more of it. So this is saying that this serving size has 37 grams of carbohydrate. So if one serving is 15 grams, 15 times 2 is 30 already, and this is 37. 15 times 3 is 45. So this is actually 2.5 servings of the 3 or 4 servings that person could have with lunch or dinner. And it's far more than we recommend with breakfast during pregnancy. What helps is the more fiber, the better. 5 grams or more of fiber really matters. in making the food take longer to break down. The added sugars and sugars are what we want to avoid. So I know now that this particular product that has 37 grams of carbohydrate, the sugars and added sugars are included in that number. And it's actually 12 grams of sugar. That's just sugar. It's no nutritional value. So I might want to look at another product that doesn't have as much added sugar. At the beginning, it's a good idea for people to really measure their portion sizes and try to use the same bowls and same plates so they know how much that measured amount looks like on the plate or in the bowl. So, for example, they could measure their cereal into the same bowl every day for a few days and know that when they measure their cereal, 3/4 of a cup would be about, that high on their bowl, for example. There's also some apps that can really help with looking things up that have big food diaries, such as Calorie King and MyFitnessPal. So you could look up any food and it will tell you all about the different nutrients in it and how many grams of carbohydrate. So this is an example of someone following this meal plan of 1 to 2 carb servings with breakfast, 3 carb servings with lunch, and 4 carb servings with dinner. So I've highlighted in this menu, in yellow is what is counted, carbohydrates, and the ones that aren't highlighted don't have carbohydrate, and you can eat as much as you want. So the person could make a scrambled egg with cheese, and that doesn't count, and they can have their decaffeinated coffee with it. They could have extra cheese if they want on the side, or some non-starchy vegetables with it, even a salad. But the yogurt would matter, the skim milk would matter, the cereal would matter if they're eating cereal or pita bread or whatever they're going to have, all counts. For lunch, this person chose some lentil soup, which was 1 serving of carbohydrate, but the grilled chicken is free, the green beans are free, they could have other vegetables that are not starchy with it. The baked potato very much counts, so you could have 1 small baked potato is fine, or if you have large baked potatoes, you can cut it in half, share the other half with someone else, or save it for your next meal. The salad doesn't count, but the fruit does count. This person chose watermelon, which is low in carbohydrates, so they can have a full cup or 240 milliliters. And the last meal, dinner, is some fish fillets, and the vegetables that are non-starchy don't count, but the rice very much counts. And this person chose white rice, but if you chose basmati rice or brown rice or a multigrain rice, it wouldn't make the glucose go up as quickly, so that would be a better choice. So the 1 cup or 240 milliliters of rice is already 3 of the 4 servings of carbohydrate. So you can only have 1 more if you want to have the full cup or 240 milliliters. This person chose fresh fruit salad. So when the fresh fruit salad is mixed with some berries and melon in combination, you can have a full cup or 240 milliliters. And here's some examples of some healthy snacks. Each of these is 1 carb serving. So the first one, you can look up for the crackers, look up on the label to find out how many crackers is 15 to 20 grams. And they're having it with cheese. They could have it with peanut butter. This snack with cottage cheese and fruit, they're choosing berries so they can have more berries. The cottage cheese is mostly protein, so that's okay. And the before bed snack is apple slices and almond butter. So again, the portion sizes, the carbohydrates is what matters here. So at Weill Cornell Medicine, where I work, we've done a lot of studies with food order. Asking the question, what would happen if you ate your carbohydrates last? Would that blunt the rise in glucose after the meal? And guess what? It works. So we've tried this in people with type 1 diabetes, people with type 2 diabetes taking insulin, not taking insulin, and now we're doing it with people with gestational diabetes. And it really does make a difference. So looking at this picture here, this subject ate the rice first and then ate the salmon and the broccoli. And after they ate the rice, the glucose skyrocketed. And then when they ate the salmon, it still stayed high, but it came down a bit. But in the second case, the subject then ate the broccoli and the salmon first, waited 10 or 15 minutes before they ate the rice, and look what happened. Much lower rise in glucose. So food order really matters. Eat your protein and non-starchy vegetables first, wait 10 or 15 minutes, and that will help to lower the postprandial glucose rise. Now we're going to talk about physical activity. So aerobic exercises really do help lower the glucose, especially after meals. So that might be a good time to do it, especially after breakfast. If the person finds they go up too high after breakfast, this is a strategy to help lower it. So cutting the amount of carbs for breakfast and taking a walk after is an important strategy. Walking at least 30 minutes most days of the week is recommended. And things that are aerobic that will lower the glucose, like yoga, housework, gardening, swimming, dancing, listening to music while you're doing it, watching TV while you're exercising at home, walking with a buddy. Try to find ways that the person can enjoy their activity and do it every single day if possible. So the summary of the management plan is eat 3 main meals every day and 3 snacks, well spacing them at least 2 hours from every meal to snack, snack to meal. Focus on portion sizes and quality of the carbohydrates, not to eat too much at once, and to choose carbohydrates that have nutritional value. Review the nutrition facts labels on the foods that you're purchasing. Even if you're cooking with them, whatever you're doing, you want to know how much carbs is in it so that you can count the carbs correctly. Practice the food order with each meal to lower that rise in glucose. So eat the protein and non-starchy vegetables first and salad. Save the carbs for last. And always include a bedtime snack with some protein and fat to feed the baby and prevent developing ketones while sleeping. So to sum this up, monitoring glucose 4 times a day, fasting in 1 or 2 hours after each meal, checking ketones first thing in the morning upon awakening with that first void, planning healthy meals and being physically active are important treatments for gestational diabetes. If they're not able to achieve those glycemic goals, then the next step is to start insulin therapy. This is a great handout, which combines everything I just said into one simple handout that you can print out and give to the person. We have it available right now in English and Arabic. And after the person delivers, they're not out of the woods. They're on a 50 to 60% increased chance of developing type 2 diabetes later in life. So we want to monitor them very closely soon after to make sure the diabetes goes away right after they deliver. It may not, about 10% of the time, which could mean they had type 2 diabetes all along as possible. So we want to screen them at 4 to 12 weeks postpartum with a 75-gram oral glucose tolerance test, but using the non-pregnant criteria. And the reason we want to use the oral glucose tolerance test postpartum between the 4th and 12th week postpartum is because it's much more sensitive to detecting prediabetes and diabetes in that first 12 weeks after delivery. After that, you don't have to do that. You could do an A1C, you could do a fasting glucose, or you could do the glucose tolerance test. And it's recommended depending on how high risk this person is and whether they are able to lose weight, be physically active, eat healthy or not. You want to monitor them every 1 to 3 years. If they are overweight or obese and meet the criteria for prediabetes in these tests, you want to offer them intensive lifestyle interventions, and you could also include metformin to prevent or delay the onset of type 2 diabetes because they're at high risk for that happening, so you want to do something. So this is just a couple of examples of open access education on the DEFA website related to pregnancy, and we have them available in English and Arabic. So on the left-hand side goes over the different foods in each main nutrient, proteins, carbohydrates, and fat, and does list some combination foods and make some suggestions about how to figuring that out in your meal plan. On the right-hand side is one of my favorites, the non-starchy vegetables, where people don't have to restrict the amounts very carefully because these foods don't have a lot of carbohydrate in usual portion sizes. Next up is snack suggestions. This is good to carry when people are physically active in case they get hungry while they're being physically active, and their glucose, if they're taking insulin, might be dropping. So these are some good snacks to carry. And all of them are equal to 1 serving of carbohydrate. How to check glucose. So after you show someone how to check their blood glucose with a glucose meter, you can use this checklist to teach them and give it to them to take home so they don't miss any of the steps. And last but not least, the gestational diabetes handout that has everything all in one place, that gives them all of the information about what it is, following a healthy meal plan, checking for ketones, being active, checking glucose, when to check the glucose, and what the goals are, all in one place. And these are some helpful links in the DEFA website.